Dear colleagues, welcome to today's EACVI webinar on quantitative assessment of left ventricular volumes and function before and during chemotherapy, with special emphasis on optimization and improvement of image quality of contrast echocardiographic examination. My name is Piotr Lipiec and I'm the head of the Department of Rapid Cardiac Diagnostics in Medical University of Łódź in Poland, and tonight, during this session, I will be your host. The aim of this webinar is to give you a better understanding of the importance of accurate and reproducible left ventricular volume and function measurements for the assessment of cardiac toxicity of cancer treatment, and to demonstrate how contrast echocardiography can be helpful in this clinical scenario. The cases illustrating these important aspects of clinical practice will be presented by two highly experienced experts, Dr. Andreas Helfen from St. Maria Hospital in Germany and Professor Harald Becher from Mazankowski Alberta Heart Institute in Canada. At the end of this webinar, of the 65-minute event, you will know how to optimize your acquisition and analysis technique of contrast images and to achieve optimal diagnostic accuracy, which we hope will help you in successful implementation of contrast echocardiography in therapy management of cancer patients. This session is meant to be highly interactive, and we strongly encourage you to actively participate by sending your questions or comments at any time during the webinar through the chat. If the time runs out before we manage to discuss or answer all of your questions, we will provide you with answers on the ESC website sometime after the webinar. So anything you need to know, just ask and we will provide you with tips and tricks for your daily clinical practice. For the best learning experience, we also invite you to participate in multiple choice questions that will be submitted by my esteemed colleagues during their presentations. And I also need to say that this webinar is possible thanks to unrestricted educational grant from Bracco Imaging. And now I will end this introduction and I will hand over to Dr. Helfen. Andreas, the stage is yours.
Thank you, Piotr. I will focus in my presentation on how to optimize contrast images for measurement of LV volumes and ejection fraction. These are my disclosures. And if we look into the 2016 ESC position paper on cancer treatments, echocardiography is recommended as imaging modality of first choice. And the paper mentions two major limitations of echo. This is inter-observer variability and image quality. And we know from numerous studies that we can reduce inter-observer variability by contrast and improve image quality. And I will give you an example. This is a patient with a lung cancer scheduled for chemotherapy, and I ask you please assess visually the ejection fraction. Is it A, normal, B, mildly reduced, C, moderately reduced, or D, severely reduced? Please vote.
Okay, so now we are waiting for the results to come in, and while we have a few seconds, is this an example of a patient in whom you would consider contrast echocardiography?
Yes, we always consider in these patients contrast, especially in those patients where image quality is reduced, as in this patient.
Okay, so we are just having the votes, and actually 44% of our viewers believe the ejection fraction is moderately reduced, so the answer is C, and 45% say that it's mildly reduced, so answer B.
So there is some sort of disagreement, yes, yep. So now let's try to improve inter-reader variability, and I show you the contrast image. And again, I ask you for your assessment. Is A, the actual ejection fraction with contrast lower than without, Or B, was your initial assessment correct? Please vote again.
I think this will be a short vote, but I also have a short question. Because you have shown the contrast image straight away, but of course it takes some time to get an IV line. So my question is, in your daily routine practice, do you obtain written consent before you perform contrast echocardiography, or do you treat it as an inherent part of echocardiography and you just put an IV line, and when you need contrast, if you need contrast, you inject it?
Yes, in Germany we have to obtain a written consent because it is an injection of a drug, and although side effects are very rare, we have to inform, of course, the patient about potential side effects and to document this. Yes.
And in Canada?
In Canada, some institutions ask for written consent like ours. However, for instance, for example, the US, there is only verbal consent of the patients. And this is interesting because usually the US is very, very picky about medical legal things. So I think this is varying from institution.
So we don't really have a worldwide standard. I guess
No.
it varies from country to country and institution to institution. Okay, so now we have our answers. And majority of our viewers believe that the actual ejection fraction is lower now that they have seen the contrast-enhanced image.
So I think what this example shows is that we can improve not only image quality, but reduce inter-reader variability.
We need to tell them whether they were right.
Yeah, the right answer is the ejection fraction was below 30%. And so the actual ejection fraction is lower, answer A. If we look into the baseline risk factors for cardiotoxicity, then there are some points we can diagnose with echo. We can look for scars as evidence of coronary artery disease. We can diagnose cardiomyopathies. We can diagnose asymptomatic LV dysfunction and, of course, heart failure, even with preserved ejection fraction. So echo plays a major role in imaging those patients. And these are the recommendations of the EACVI, what we have to do in case of reduced image quality for quantitative assessment of LV volumes. And the guidelines points out contrast echo should be used when 2 or more contiguous LV segments are not clearly visualized. This is a class A, class 1, level B recommendation, and we can use the normal values for grading of the reduced ejection systolic function of the left ventricle. Sometimes imaging quality is quite good, but it is difficult to exactly measure ejection fraction like in this patient. I show you the borders between the compacted and the non-compacted myocardium. These are the end diastolic and these are the end systolic images. Sometimes we can look for these black recesses here, bright, filled with contrast. This helps us to define where is the border, but there is some uncertainty about the exact border. So in these cases, the guidelines recommend that we should consider contrast irrespective of image quality when clinical management depends on accurate measurement of LV function, such as monitoring of patients treated with cardiotoxic drugs. This is a class 2A, level B recommendation. So how can we describe the process of optimized images? I have divided this process into 3 steps. The first step is that we optimize the dose of the contrast, then we optimize our settings of our machine, echo machine, and at least we optimize the scan plane. First of all, the dosage. We use very often an infusion pump for this question, but infusion pumps are not available in all echo labs, so probably most of the labs use a bolus followed by saline to flush the line. And what results then is that there will be some kind of overdosing in the very initial phase when the contrast fills the left ventricle. And I recommend to look first only at 2 points in the left ventricle, on the apical zone and on the basal zone. And overdosing means that in the apical zone there's an intense bright signal of the contrast agent, and due to signal attenuation we have in the basal zone weak signals. And I show you an example. This is an overdosing after a bolus. Here are the strong signals in the apical zone. The border is a little bit blurry, and it is impossible to define the border between the compacted myocardium and the cavity here in the basal zone. So if we wait a few minutes, then there will be a dilution of the contrast agent, and there will be a kind of underdosing. It will be difficult to define the border again. The cavity is inhomogeneously contrasted by the contrast agent, and we have a reduced signal intensity. So in this patient, I recorded the images about 30 seconds after the contrast agent filled the cavity, and I think the contrast concentration is good in this patient. And now the next question is how to optimize our transmit power or mechanical index. And for this purpose, we have to look again in the basal zone. Here are these dark edges. I think in this patient we can decide where the endocardial border is, and the apex is filled very well, much better here than in this image. And these are how we recognize a too low transmit power. We have a weak or quite normal signal in the apical zone, and we have weak signals, especially with these dark edges between the mitral valve and the myocardial and the muscular part of the septum and the lateral wall. And on the other hand, a transmit power which is too high can be diagnosed by destruction of the bubbles in the apical zone on the one hand, and a strong signal in the basal zone, even with a good contrast up to the roof of the left atrium. So the third step is that we have to optimize our scan plane, and it is really important that we avoid foreshortening. And the criteria of an unforeshortened view only by the form of the left ventricle, not by measuring any dimensions, is that the apical segment here exhibits almost no systolic thickening, and that it shows the slightest thickness of all wall segments. Compared to this one, here there is a wall thickening, and it is quite as thick as the septum. The next step is that we now focus on the intermediate zone, and we have to look for an interference of the papillary muscle with the endocardial border delineation, and we have to look for rib artifacts. And for the papillary muscles, I prefer to look first at the personal short axis view and to look how is the position of the papillary muscles. Most often you find this situation where they are more or less horizontally orientated, or in this position where there is a slightly ascending position. This is rare, it's more than 45%, and this is rare too. This is more a descending position. And this has an impact on our scan planes. This red line shows the scan plane of the four-chamber view, and it is obvious that we can exclude papillary muscles in this situation and maybe in this situation, but it will be difficult in this situation. And again, the two-chamber view here, the blue line, it is easy to exclude papillary muscles in this orientation, but here it is impossible to exclude the papillary muscle from the scan plane. So I think it's helpful to first look at the location of the papillary muscles and then to record the images. The next thing is that we have to avoid rib artifacts. The rib here is here, and then because of the use of a low transmit power, we have strong shadows and they appear as straight lines, and it is impossible to delineate the endocardial border in this region. If we look carefully on these images, here is some kind of attenuation, and this means we have some kind of overdosing. And on the other hand, here is a little bit swirling with high signal intensity, so we have a little bit too high transmit power. And this results in strong contrast signals from the microcirculation, for example in this area here. And the signal noise ratio between cavity and microcirculation is not very good. In this situation, the guidelines recommend to use a flash. A flash is a sequence of 3 to 5 frames with a high mechanical index. And I show you the still frames. These are the anti-diastolic frames. And here it is much easier to delineate the compacted myocardium as in this frame where there are bubbles in the microcirculation and generates some sort of pseudo contrast. So consider a flash. Then we have to localize the true mitral valve ring, and this is not so easy with contrast. It is very easy without contrast, but it is sometimes difficult with contrast. And I zoom this in, and as you can see here, the true mitral valve ring is divided from the tip of the muscular septum by the membranous part of the septum. And this is a source of an error. If you use the true mitral valve ring here, then of course you measure a higher volume than if you, as if you measure from the muscular part of the septum, like here, the red dotted line. And this is quite a big difference of 15%. So we have to localize the mitral valve ring. The last step is a very important one. We have to select an appropriate recording. This was my first recording, and I was not very satisfied with this loop. And 6 seconds later, I recorded this one by asking the patient to breathe in a little bit and hold the breath. Because first of all, there is a homogeneous contrast in the cavity. This is okay. Transmit power, yes, it's okay. There's a little bit destruction in the apex. We have a good signal here. We can really localize the mitral valve ring, perfect. But what is a little bit unsatisfying is that here there is an interference of maybe a part of the papillary muscle or a tuberculation. And I think it is better to delineate the border or define the border here in this. And I show you the measurements. These are the end-diastolic frames. And here we have, although the length of the left ventricle is the same, 7.6 centimeters, the volume is different, about 20 milliliters difference between left and right. And these are the end systolic frames. And again, there is a difference of 10 milliliters, although the length is the same, 6.8 centimeter. So this introduces a kind of error, and in the end we have a difference of 4% in the ejection fraction, only by selecting a better or less appropriate loop. So I conclude we should consider contrast irrespective of image quality when clinical management depends on accurate measurement of ejection fraction, like in patients treated with cardiotoxic drugs. And I suggest 3 steps to optimize contrast images. The first one is that we optimize the dosage, then we optimize the transmit power, we optimize the scan plane, and at least we should record 3 times 5 loops of each of the 3 apical scan planes, and then select an appropriate recording for the measurement.
Thank you for this impressive presentation. We have questions coming in. I have one question of my own related to the last slide, recording at least 3 times 5 loops of each of 3 correct apical scan planes. It may take some time. So some of the institutions, some of the people performing contrast echo use triplane imaging, multiplane imaging, in order to shorten this time and to assess LV volume and function this way. What's your opinion about that?
I think even without contrast, it is really difficult to use triplane images because of the frame rate and the temporal resolution. And with contrast, both is lower volume rate and temporal and spatial resolution, and this is one of the reasons why it is not recommended by the guidelines. It is a class 3 indication to use 3D volume data sets or simultaneous tripline imaging, and I think the 2D images are good too, and the time is not so much. So I recommend to do it with 2D.
So for now we stick with 2D. You've addressed the issue of optimization of mechanical index. Could you quickly remind our audience the imaging mode that needs to be used for LV opacification?
As a standard, most vendors add a software in the echo machine for LVO. This means left ventricular opacification. And very often you have to activate a special software which gives you a very sensitive mode for contrast imaging. This is a technique of a multipulse technique, like phase inversion or power modulation. This is the image modality recommended by the guidelines. But you have to ask the vendor to activate it on your machine. And with these very sensitive image modalities, you may use a mechanical index of 0.1 up to 0.15, something like this.
And a question from our audience related to perfusion assessment, because you have shown the flash technique, which can also be implemented in order to use perfusion. And the question is how frequently perfusion assessment by contrast is helpful for these patients.
I think the focus in this group of patients is to measure ejection fraction and volumes, and to make a follow-up in this patient which is reliable. And I use the flash to reduce the perfusion signals. I don't want perfusion signals because they reduce the signal noise ratio. I want to have a dark myocardium and a bright signal from the cavity, and a high contrast. So for me, in this group of patients, there is no role in perfusion imaging. The less perfusion signals, the better.
Thank you. We have more questions coming in, but I think some of them will be addressed by the next presentation, and if not, then we will try to answer them afterwards. So right now, I would like to invite Professor Becher to present his cases.
So Dr. Helfen has given us a very detailed and practical advice on how to record images for assessment of LV function in patients with undergoing cancer treatment. Now it's my job to go with you through the actual analysis of these recordings. So these are my disclosures. And I want to start with these loops here. Because that's what we do usually in clinical practice. Probably most of us in our institution, we assess the LV function by looking at the moving heart. We can do it during the exam or we can do it offline, and then we make a semi-quantitative assessment by judging this ejection fraction, for example, as being normal. And in our institution, we then give a range and say this is probably more than 65 to 70. It's a very good dynamic left ventricle. However, this is not adequate in patients whom we assess for LV function undergoing chemotherapy with potentially cardiotoxic drugs. In these patients, we have to look at the still frames. And you see, the problem with the still frames in non-contrast images is that both in the 4-chamber view top left and the 2-chamber view top right, the borders are blurred, and it's very difficult to trace the cavity to assess the left ventricular volumes in systole and in diastole. Now you see, this is so easy even on the still frames with the contrast echocardiogram. Now let's go to a case. I will just give you the results of the assessment, and we'll look at the images later. This is a 48-year-old female patient with breast cancer, and she was assessed before initiation of chemotherapy with trastuzumab, which is potentially cardiotoxic. Contrast echocardiography was performed, as we heard, because it's a standard now, but in this patient, the endocardial definition was also suboptimal without contrast. The LV size was reported as normal, ejection fraction as 40%, and a normal diastolic LV function was reported. The global longitudinal strain was reported as 18.5%. So next is I will ask you a question to help give some advice whether it's okay to start chemotherapy with trastuzumab in this patient. The answer A is yes. The answer B is no, we cannot start because both EF and GLS are abnormal. C, we cannot start because the reduced GLS, a cardiology consultation should be performed before the start of chemotherapy. D is no, because there are discrepant findings between the GLS and the EF, and another imaging modality should be applied. And no further, that's E, answer E, no further information on the quality is necessary. So please vote.
Okay, so now we have around 1 minute for the results to come in. So I would like to use this time to ask you a question which will summarize a few questions that have arrived even before you started talking about global longitudinal strain. Our viewers are asking how to combine global longitudinal strain assessment with contrast imaging from practical point of view.
In our institution, we do the global longitudinal strain on the non-contrast imaging images because the strain algorithms do not work well with the contrast. They are not adjusted to the contrast in the ventricle. There are some activities in measuring strain on contrast images, but they are not yet ready to be recommended in clinical practice. However, I want to say, If the image quality is bad, we have to question the strain results, because strain is only reliable in patients with optimal image quality. And that is also mentioned in a previous guideline paper of the ASE.
Okay, and coming back to your question, which turned out to be quite difficult actually, because we have a large variation in answers, but the majority, 28%, well, most of our viewers, 30% now, say that the answer is correct. No, because of the discrepant findings in other imaging modality should be applied.
Yeah, that's an interesting answer, and it is in a way discrepant, I agree. And I will show you now what are the normal values. So first of all, what is my answer? And we can discuss that. I think before we make any statement about the values, we have to give also a statement about the quality. We often forget that, but in these patients, I think it's very important that we say, also in our reporting, these are high quality recordings, and we think this is supporting our results. Now let's go to the guideline paper Dr. Helfen mentioned already. So this is the algorithm what we should use when we assess patients before chemotherapy. So we should do, of course, an ejection fraction. We do it always with 2D echocardiography and not with 3D, same as Dr. Helfen. And we should use GLS. So if the ejection fraction is below 53 or the GLS is abnormal, and a normal GLS, according to the last publications of the European Association Cardiovascular Imaging, is 20%, then the patient should have a cardiology consultation. So in our patient now, these are concordant results. So both the ejection fraction and the GLS are reduced. However, a GLS of 18.5 is pretty high in relation to an ejection fraction of 40%. I agree, and therefore I think there is some truth in answer D. Now, if both are normal, we carry on with 3 months follow-up of the patient. So what are the quality criteria? Now, I will just go on quality criteria starting at the point where Dr. Helfen ended. He already proposed us how to select the right loops. So here what we should do. We should use the biplane Simpson method, and we usually report only the results from one beat. Only in a patient with atrial fibrillation, we analyze several beats, 5 beats, and then report an average. The end diastolic frame has to be identified, and it's the first frame after mitral valve closure. We just heard this is not always possible to see. So what you do instead, you look for the largest LV cavity. End systolic frame is always the smallest LV cavity, and that's easier to find. And then we trace the border, starting on the septal ring in the 4-chamber view and in the inferior mitral ring in the 2-chamber view, and connect the start and end point of the contour at the mitral ring with a straight line. And finally, we look at the length as the distance between the midline connecting the mitral ring, the midline connecting the middle of the mitral ring to the apex. So what is how can we find the appropriate frame for end diastolic volume measurements? So what is very important that you take the time and you go frame by frame through the loop. Normally, the ECG recording, the loop recordings start with the R wave and usually towards end diastole. But the first frame is not always the end diastolic frame. So this is the end diastolic frame of the loop. And now see, if I move forward, it's getting a little bit larger, and then it's getting smaller if I go further. And you toggle between these frames forward and backward sometimes to find the loop. So in this case, it's very close, but there is a difference, and that can make an error if you not identify the correct loop. So The next step is, and that has already been mentioned, is we need now to identify the correct start and end points of tracing the LV cavity. And for that purpose, it's helpful also to look at the moving image. I said we are doing mostly of our analysis on the still frames, but here we easily can see where is the start and the end point. And I highlighted it with a yellow cross here. So in the two-chamber view, this is usually not a problem. And you can see also a little bit here at the anterior mitral ring, this bright echo Dr. Helfen mentioned in the previous talk. It may be a little bit more difficult in the four-chamber view. So in the four-chamber view, again, we can see where the myocardium ends, and there is no more myocardium very well, highlighted by the yellow cross on the lateral ring. So this is pretty easy, but on the septal side, it can be difficult, as we heard. So what we do then usually, we just assume that the start point is at the same level as the lateral ring, and then use that as a landmark for our tracing. So once we have identified the start and the end point, we can easily trace along the endocardial border, and you see this is pretty easy to do because the endocardium is so well delineated, and actually it's the compact myocardium what we should trace. So the next step what we do is we have to compare the LV lengths in the four and the two-chamber view. This is the length from the middle of the mitral ring to the apex in the four-chamber, in the two-chamber view. Now, why is that important? Now, this is a very important quality marker. When you have a major difference in the length between the four-chamber and the two-chamber view, then the view with the shorter length is probably foreshortened. And there is good evidence that using foreshortened views falsifies our results and gives, in the end, incorrect EF measurements. So when you look at the volume, which is usually displayed in the right upper corner, I zoomed it up in this patient. We usually get the volumes, and we also see here in the third line the length of the ventricle, which is automatically provided by the software which we use for analysis, and it's 9 centimeters in this case. In the four-chamber view, it was 8.8. So is that good? Yes, that's certainly good. We looked at a series of 700 patients, how this difference in length affects our reproducibility and or variability of measurements. And what you can see here on this slide, where on the x-axis we see the difference of lengths, and on the far right we have a difference of lengths more than 4 millimeters. The columns are all higher, indicating higher error estimate, which is on the y-axis in the patients. So from our experience, we recommend that when there is a difference in the length of the ventricle in diastole between four-chamber and two-chamber view of more than 5 millimeters, to look for other loops to do the measurements. And Dr. Helfen mentioned we should always acquire several loops, so we have enough data then to select loops which match in length and give then reproducible results. Let's go and move to another patient. So this is a patient who is 57 years old, a female, also breast cancer, and she comes for a follow-up during trastuzumab treatment. Her baseline ejection fraction was 65% and the GLS was 22%. And now she has an ejection fraction of 48 and a GLS of 15.8. Let's look at the images because now I will ask you again for your advice. So you still see the 4-chamber and the 2-chamber view with contrast. So how would you judge the quality of the follow-up echocardiogram? A, you are not happy, the quality is not good enough for reliable assessment of the LV function. B, the quality is acceptable, the EF is reduced. C, the quality is acceptable, the EF is normal. And D, the quality is acceptable, the EF is borderline. So you have now time to vote and also to look at this 4 and the 2-chamber view.
Please vote. And during voting, I would like to use this time to ask you one of the questions that has just arrived. And the question is echocardiographic screening necessary in case of every chemotherapeutics used?
No, yeah, that's a very good question. And we should be more clear enough that the EACVI has provided a list of cancer drugs which are cardiotoxic and have highlighted those drugs which are where we have to do screening. So in summary, we should only do screening in patients who undergo cancer treatment with cardiotoxic drugs. And the most frequent of these drugs are Adriamycins or cyclines and trastuzumab, or what is also the other name is Herceptin. So it's mainly in those patients. Otherwise, we wouldn't be able to cope with this workload. Was a learning point here, and what Dr. Helfen also suggested. We are now reducing our variability. We are having the majority of our votes at the same. So this is exactly what we want to achieve with this. So just this is also what we said. It's exactly what we expected. So these are the reference values for the follow-up of our cancer patients. And you see, if we have a drop of 10 points to of the ejection fraction to less than 53%, then we diagnose cancer treatment-related cardiac dysfunction. In this situation, we don't need GLS anymore. The GLS is only helpful if we are not below these thresholds, and then depending on the amount of reduction, a 15% relative reduction, we would diagnose subclinical dysfunction. But in our case, the GLS is only a confirmation of the contrast findings, but with the contrast echocardiography, we usually are pretty confident what we see. But we have to ask, can we really see a change of 10%? And the 10% in this paper comes from an earlier recommendation of the American Society of Echocardiography, which suggested that echocardiography laboratories should have a quality program to ensure that they can see a difference in ejection fraction by 10%. Now, where do we stand with contrast echocardiography? And we looked at that in a different way. And we looked at it in a way which I always was interested. What is the minimum change in left ventricular ejection fraction which can be measured with contrast echocardiography? And it's not so difficult to do that. We just repeated the measurements in 150 of our patients. But to be very honest, in this study, we only included patients in whom we got recordings which have all the criteria which were presented by Dr. Helfen and all the quality markers which I have presented so far. And then you can use a standard statistical program, measure the standard error of measurement, and get finally the minimum detectable difference. And the minimum detectable difference in EF with this method is as low as 4%. So I think we are pretty confident to see changes if they are 5% or more. Now, this is under the best condition, and in clinical practice, it's probably a few % higher if we also have to include some patients with suboptimal, but it clearly shows us where we stand with our accuracy in contrast echocardiography. And just my last slide, also from the ESC position paper, to highlight you the importance of accurate measurements of the ejection fraction. Look at these action points which come from different scenarios in patients followed by under treatment with cancer drugs. And you see when the ejection fraction decreases, no matter what the EF is, we act upon. And even if the ejection fraction remains normal, drops but remains normal, and the GLS decreases by more than 50%, we still do not change chemotherapy because there is not yet enough data to support prophylactic treatment or any other intervention in these patients. So, in summary, I want to conclude. There are critical steps for the EF measurements even after we have acquired optimal images. We have to avoid post-extrasystolic loops. I didn't mention that in my presentation, but that is very obvious, and we also do when we wouldn't use contrast. We have to select and thoroughly select frames for the end-diastolic and end-systolic frames. We have to be very cautious in identifying the start and end point for the tracing, and we also should always compare the LV lengths in the 4 and the 2-chamber view. Applying these criteria in contrast echocardiography results in highly reproducible EF measurements comparable to MRI, what we shown earlier. Decisions on management depend mainly on the ejection fraction. Thank you.
Thank you for this excellent and practical presentation. I believe many of the questions that have been submitted you have answered during your presentation, but there are still a few outstanding, and I will try to group them into certain categories. There are questions pertaining to automatic delineation of the endocardium and several algorithms that are available for that. Can you comment on the usefulness of such algorithms in cases of such patients and in contrast echocardiography?
For contrast echocardiography, there is only very sparse data on using this algorithm, so we would not recommend it. And the algorithms so far for automatic quantifications have been developed for non-contrast studies, and they have their limitations. They also have their limitations in non-contrast echocardiography. So in general, I would recommend to follow the guidelines, and that means in these patients to measure the ejection fraction with contrast echocardiography.
Okay. The next question is looking at the right ventricular function. When you have an image, contrast image, do you also look at the right ventricular function and assess it by means of contrast echocardiography?
No, we don't. It would be interesting to look at that because certainly for some cancers that may roll, but I'm not aware of any larger studies and providing reference values. So I don't think it's not yet ready for clinical practice.
And another group of questions relates to the subject of patients in whom we may fail with imaging, even with contrast imaging, for various reasons which have been mentioned in those questions. So in your practice, in your research, how often do you come across a patient in whom, even with contrast echocardiography, you cannot assess LV function accurately?
I can give you a figure from the study I mentioned on the variability of the EF measurements, and that included 700 patients, and there were consecutive 700 patients, and 7 out of these 700 patients were not accessible. So there are some rare cases where we are not able to do it. This happens, but fortunately it's very rare.
Okay.
But 7 of 700, that's 1%.
Yeah, 1%.
That's it's not much.
Another interesting question concerns time intervals between echocardiographic assessment in patients undergoing chemotherapy. What would you say would be the recommended time intervals between repeated examinations?
The guidelines are very clear. For patients undergoing trastuzumab treatment for breast cancer, you have an initial measurement, and then every 3 months for a year. That's recommended. For Adriamycin, there is treatment at the beginning, and then with a consecutive increase of the dosing of the Adriamycin, you will report it. Otherwise, you do it after finishing the chemotherapy, and again after 6 months after finishing chemotherapy.
And I think it depends on the risk factors and how severe they are in the baseline examination.
Yeah.
If you have a patient starting with an ejection fraction of 40%, then maybe it is a good idea to make these follow-up intervals a little bit shorter. Yeah. And not to follow in this point.
Mm-hmm. An interesting concept has also been submitted. Correlation between the calculation of stroke volume by end systole and diastole, tracing in end systole and diastole, and with Doppler technique in left ventricular outflow tract and velocity time integral. Do you look at the correlation between those values to see how accurate your tracing is?
No, but we do a study on that. It's funny that this question comes up, because it's a very good question. Because in principle, when we say contrast echocardiography is very accurate, we should have a very accurate measurement of the stroke volume. So we started to compare the stroke volume with the stroke from contrast in the LVOT. But this is not in cancer patients. This is not in cancer patients. And we see a correlation, but it's not as good as we were expecting. And if the colleague who has asked this question comes to the EuroEcho meeting, I have a poster, or one of my fellows has a poster on that to discuss these issues. But the short answer is, I don't think it plays a role at the moment for the monitoring of cancer patients. We are not specifically mentioning the stroke volume.
Okay. And
I think the problem is the LVOT and to position exactly the sample volume and the plane of the mitral, the aortic valve moves, and so the sample volume doesn't move. It's steady. So there is some kind of error, and we know this from calculation of aortic valve stenosis, that this is really difficult, and we know this from optimization of CRT devices, that stroke volume measurements are really very, very demanding techniques, and I think it's not usable in clinical routine at this time.
A lot of questions are related to stopping chemotherapy. Is there a cutoff of the ejection fraction at which you stop chemotherapy? Some people propose different cutoff values in questions. So do you take such decisions based on ejection fraction? Do you stop chemo?
No, we are cardiologists, and we are not making decisions on stopping chemotherapy. We help them to initiate chemotherapy or facilitate that, but when the chemotherapy is ongoing, we give the results to the oncologist. And it's it depends really on the oncologist, it depends on the tumor, it depends also on the patient, because the patient will be consulted. There's definitely, if an ejection fraction drops to 30%, our oncologists will discuss with the patient a pause. But at the same time, we will, as you have seen on the second last slide, initiate a treatment with ACE inhibitors and beta blockers to improve the patients, and then see the patients again within 4 weeks again. And often you see then they come up again. So the decision has to be made patient per patient, but the final decision is on the oncologist.
I agree.
You agree? Okay, I agree too. And I guess we have time for one last question. It's so hard to choose one. There's a question regarding for how long should we screen patients after chemotherapy? Well, not screen, but assess the LV function after stopping chemotherapy. Should we do that? And if so, for how long?
We have a the answer cannot be made easily, and it's actually still not very clear. So we are now getting patients who had cancer as children, and when they're grown up, they are transferred to us as the adult cardiologist. And so far it was that the patients, when they had a normal ejection fraction then at adulthood, then they were discharged. But we have learned now that some of these patients, when they are reassessed years later on, have a decreased ejection fraction. So several centers, including ours now, looking in that a little bit more systematically to collecting that in a registry. So the correct answer is I don't know. I don't know, but usually in youngs is at least when they are adult, if they have any reduction in LV function, then you should review them on a yearly basis. That's our practice. But when they are normal, they are often discharged.
Okay. Time is running fast when we are talking about interesting things, and I'm sorry to everyone who hasn't heard answer to their question. We will try to prepare answers afterwards, and now we are approaching the end of the webinar, so I would like to close this session by reminding you the key messages for your daily clinical practice. So first of all, please remember that critical clinical decisions depend on left ventricular assessment in patients undergoing cancer treatment. Mainly, they depend on the assessment of ejection fraction. So according to EACVI recommendations, such situation warrants consideration of contrast during echocardiography, irrespective of image quality. That's Class 2A recommendation. Secondly, when you acquire contrast images, remember 3 elements of optimizing the quality, and these are optimizing the dosage of the contrast agent, optimizing the machine settings, mainly the mechanical index, and optimizing the scan plane. And thirdly, when you measure ejection fraction, identify the correct frame for measurement, find the mitral annulus level, and make sure that you do not use foreshortened views. So we will now close this webinar, and I would like to thank Dr. Helfen and Professor Becher for their excellent and highly practical presentations. I also would like to thank Bracco Company, which supported this webinar with an unrestricted educational grant. So we hope you enjoyed your time with us, and you will be able to view this webinar again if you want to, offline on the ESC website in a few days. Thank you and good night.